So any questions from last week? Anything at all? All right. The quiz generally was pretty good. I think the second and third question most people got pretty close to full credit on. The first question, however, there was a little bit of some variation there. So a lot of people got the epinephrine correct, which is good. Make sure you're very explicit. A lot of people came up with the right dose, so they either went with that 0.01 milligrams per kilogram, so they came up with that, 0.45 milligrams, or some people would max out at 0.3. I think that's pretty reasonable. I think in a lot of places they'll just max out at what the EpiPen dose is. That's fine. I wouldn't go above 0.5 though. That would be quite a bit to get, and most people got it right. The intramuscular is generally the route that you're going to administer it. Make sure you have the right concentration, right? Because we have two varieties that are out there. We have a 0.1 milligram per ml concentration, that's that 1 to 10,000, and we have a 1 milligram per ml concentration, that's 1 to 1,000. If you get that screwed up between the two, you could underdose your patient based on the volume that you would calculate to administer, which is why I was trying to kind of ask for that sort of thing, like how much volume are you going to actually give? Because that's what the nurse is going to ask. They're going to say, well, that's fine, you got the dose, but I got to calculate that into a volume to administer. And if you can kind of help out with that and double check, then that's going to be better for the patient, right? That way you at least have two pairs of eyes on doing the calculations. And in a situation like this where a person's coming to anaphylactic shock, like that can be pretty high stress. Like your ability to do math is not super great in those kind of cases. You want more minds on it than just one, right? The other thing was the cocktail of medications to receive along with that was a little variable as well. So what other meds should a patient in anaphylactic shock get? So fluids is going to be big, right? They're hypotensive, they're tachycardic. So a lot of people had the correct fluid bolus amount, right? So you want to do a fluid bolus, and then you would, in addition, you would start them up on maintenance fluids, most typically, right? You give them a bolus, see how they respond. Sometimes they may need 2 or 3 boluses, depending on it. But then you get them on a maintenance rate of NS, right? So that would be the correct fluid to use. Be very careful when you calculate your volumes, right? A lot of people came up with the 4-2-1 rule. They came up with 85 as being the correct volume to give, but they might have put mLs per kilo per hour. You gotta be careful with that. You do mLs per kilo per hour, 85 for a little 45 kilo guy, he's almost getting 4 liters an hour of fluid, right? Someone doesn't double check that, you could kill somebody that way, right? You can give the pulmonary edema, lungs just filled with fluid, can't oxygenate, they're done, right? That's happened occasionally, not maybe with a kid that big. Someone probably would catch something like that. But there's been cases where like a little neonate will have a liter bag of saline hung on them, and all of a sudden they go into flash pulmonary edema, and there's been some significant adverse events caused by stuff like that. So be careful with fluids. But yeah, most people have the calculations done right. Just watch your units. Units are super important, especially when dealing with peds. What else should they get? Yeah, so albuterol was a good answer. I think that was reasonable. That was kind of like a plus minus you could do. I think the epi would definitely help to treat that, right? Because again, the epi can help with that beta-2 agonism effect. But the kid's wheezing, so again, you can give him albuterol. I think that would be totally fine. Albuterol, ipratropium, if you want to do the combo, again, totally fine by me. What else should I get? Yeah, so corticosteroids is super important. A lot of people miss the corticosteroids, right? You need to have a corticosteroid on board because the epi helps with the immediate kind of inflammations happening here. We need to worry about kind of the long tail on that. So a lot of people were correct to either like give them a corticosteroid right then and then maybe send them home on a prescription for a few days. 3 to 5 days is probably sufficient for that sort of thing. Thought that was pretty reasonable. And what else would they get? Antihistamine is the other big thing, so a diphenhydramine would be a good option. Now, for a kid who's coming in for anaphylactic shock like this, they're wheezing, they're hypotensive, like what route would you want to give a lot of these meds? Typically IV, yeah. So IV or IM, if you don't have IV access, that would be the typical route. If it was a much less severe case, if they were just coming in, they had urticaria and their rash all over, oral is totally fine if they can tolerate it. A lot of these kids also may end up like throwing up as well, especially when they're really tachycardic and they're freaked out and they can't breathe. That could be another thing where you'd see, IV use being pretty good for that sort of thing, right? Yes, ma'am.
So for the steroid, you would give it both in-house and prescription?
I would write them for a dose there, and this is probably not someone who would end up being discharged home directly. This is probably someone you'd monitor for like 24 hours or so, just based on how ill they are. They would probably end up getting, either a dose in the ER, IV followed up by PO steroids in-house and then sent home with a prescription, or we would just leave them on IV maybe for 24 hours and then switch them over to PO. It depends on the reaction, how well they're responding, right? Because again, steroids take some hours to actually kick in and really be effective, and IV is going to be a little quicker than the oral form, right? So is that what other meds could we give? Anything else? A couple of people said Zantac or like an H2 blocker. That would be reasonable as well to help with some of the GI effects. I think that would be totally fine. That's kind of on the level of albuterol being kind of like a plus minus thing. So I usually take off points if you were missing a therapy. Those kind of core things that a person should get, or something goofy like something omitted, or if there was like the dose was like just crazy wrong, right? That would be another thing where I'd probably take off some points on that, either due to units being incorrect or anything like that, right? But overall, I think most of you guys did pretty good. I don't expect you to be perfect clinicians yet, so some of the style stuff I tried to put some comments on. I wasn't necessarily taking any points off of that stuff, but usually things that were omitted were the main thing I took points off. So if you have any questions or you feel like you were graded unfairly, then we can talk about it and go from there. Any questions on the quiz? Like I said, most people did really good, so I'm not too concerned. I'm sorry? I did put yeah, so if I didn't write anything, then I did not have anything to comment on. But most people could see their comments. I've heard a few people give some feedback. So, okay, anything else? All right, we got a lot of slides to get through, so let's continue talking about hyperlipidemia. So this slide's pretty good at helping you kind of keep track of what these different drug classes are going to be good for. So again, statins are gold standard drug for treating hyperlipidemia for the most part, as we'll see with the guidelines in a second here. The other things just to note, and don't memorize these numbers, just kind of trends here. Things like your nicotinic acid, things like your fibrates tend to have pretty good effects on your HDL and lowering triglycerides. These tend to be kind of the most important things for that. Imagine, if you had a test question where a patient was like, hey, they only have like an isolated, low HDL. Why is low HDL important? That's a negative. It's a positive risk factor for cardiovascular disease if you have a low HDL, right? So you want to get that up in some cases. If that was your only issue, if all the other cholesterol is looking good, then you can use something like a fibrate. You could use something like niacin to help get that up, right? That could be one thing you could do. Similarly, if they had just an isolated hypertriglyceridemia, that could be another thing you could potentially try. So you can just kind of keep some in mind these kind of things. Notice things like resins, are not going to have good effects on triglycerides. So that is their issue. This is not going to be a good drug to help with that. So notice those kind of trends there. Does that kind of make sense? So normally I'm not going to have you calculate lipids on the test, but this is where we actually get these numbers from. Typically your total cholesterol that gets reported out would be your HDL plus VLDL plus your LDL. And again, LDL is going to be kind of our surrogate for triglycerides, essentially, because we know that when you're looking at those graphs, the VLDL had a really high proportion of triglycerides versus cholesterol esters. Now, typically what we would end up doing is taking the triglycerides and dividing by 5, and that gives us an idea of what the VLDL content actually is. And so that's where you get the calculation from. Notice here that our old goals for treating hyperlipidemia used to be based on the LDL concentration. We were really shooting for specific goal numbers, things like less than 100 is optimal, trying to get the HDL up. We don't really care about the numbers so much anymore. Our goal is to try to get them on as aggressive a therapy as possible, because with statin therapy, I should say, because we know this has improved morbidity and mortality due to cardiovascular disease, right? So because of atherosclerosis risk, we're going to try to, we mentioned those kind of pleiotropic effects of statins, how they kind of have extra effects rather than just affecting cholesterol. They can do things like inhibit inflammation. They can help with those plaques. Because of those additional benefits, we're not shooting for that LDL goal. We're going to use our we're going to use our LDL to measure to make sure the patient's being compliant, right? Because if I put someone on 40 of rosuvastatin and their LDL doesn't drop, they're not taking the drug, right? It just means that no one is that resistant to these statin drugs, right? So basically, the updates to the guidelines are saying, like, well, who should be on either moderate intensity or high intensity statins? That's how they're kind of the nomenclature is now. And basically, they're trying to say how high of a dose of a statin should you try to get a patient on to. And there's kind of 4 categories of patients we're going to look at. Mainly, the 4 groups of people to benefit from statins are going to be those that already have clinical atherosclerotic cardiovascular disease. So what do you think that is? What do you think that means? They have a specific definition in the guidelines, but if you could think of anything. So what would be some signs of cardiovascular disease with atherosclerosis? What could your patient manifest? Chest, yeah, so angina. They have history of angina. That's an obvious sign they're causing myocardial ischemia. What else? Maybe not high blood pressure. That's probably certainly someone who's on that trail to eventually develop that. What if they've had a previous MI? It's probably someone who has atherosclerotic cardiovascular disease. So those kind of obvious kind of things like, okay, listen, they have a history of this. They are going to benefit. They're going to hopefully have less repeat MIs. They're going to live for longer, hopefully. Individuals who have pretty high LDL, that would be another group who would benefit from this. And then patients with diabetes who are 40 to 75 years of age with relatively high LDLs, and they don't have the ASCVD yet. They don't have that yet. They could still potentially have benefit. And then those without that clinical ASCVD or diabetes they have an LDL within this range, and they have an estimated 10-year ASCVD risk greater than 7.5%. That's just basically saying that they have a risk of developing cardiovascular disease within the next 10 years greater than 7.5%. Okay, those patients can still benefit as well. And this is all known from these large kind of studies we've done. So I'll show you what that what a calculator looks like in just a second. But basically, the older your patient is, the more a history of that heart disease, they have diabetes, they're going to be more likely to be put on these kind of high-dose statins. So again, you kind of go through a kind of an algorithm here where you're saying, okay, do they have that clinical ASCVD? Most of the time, you're going to end up putting them on a high-intensity statin. And I'll show you what those drugs look like in just a few minutes here, what doses we're talking about. If not, they're older than 75 because we know that they're more likely to have organ impairment, things like that. You maybe just go with a moderate dose in statin. And generally, the dose is going to be limited by what your patient can tolerate, right? So when they develop side effects, that's when you kind of need to start backing off your dose a little bit. This is what the patient can tolerate. Now, if they just had an LDL that was greater than 190, again, you try to put them on high-dose statin, really get those LDL numbers down to show that we are having these kind of positive effects here. If they had diabetes, and they're not particularly elderly, you would either use a moderate intensity statin, or if they had that high risk, right, the greater than 7.5%, you didn't put it on a high intensity. So again, you're risk stratifying your patient. How likely are they to develop cardiovascular complications of this, and then kind of treating appropriately. And then you can do a calculation. If they're above 7.5%, then you have a little bit more wiggle room to either do like a moderate high intensity kind of dosing. So how would you do that? Basically, there's calculations online. I wouldn't know how to do it by hand if you put a gun to my head, but I can at least look it up and Google it. I can find these kind of things. And they're taking into account several patient factors. They're looking at things like gender. They're looking at blood pressure. Are you receiving treatment for your blood pressure, right? Because obviously that shows that you're more at risk for developing cardiovascular disease. Do they have diabetes? Are they a smoker? Cholesterol? This sort of thing. They're looking at that to see what your 10-year risk for developing ASCVD is. Okay. If it's greater than 7.5%, then you're automatically on the list to receive a statin. And so this is a table out of the guidelines that kind of shows you what they're looking for. Notice here for high-intensity statin, the two drugs they're mainly focusing on is atorvastatin and rosuvastatin. Those are kind of your go-to sort of statins for really high-dose, really potent statins. These are going to be the strongest ones, essentially. If you just need moderate-intensity statins, you can get away with, and again, I'm not going to have you memorize the dose necessarily. I may ask a question, should a patient get high intensity versus moderate intensity statins? That may come up on the test, but I'm not going to have you ask which dose. I would probably know that atorvastatin and rosuvastatin are included in that high dose, that high intensity statin category, just because these are the most potent, and you should probably be gearing more towards using those, if anything, if your patient really is at high risk. No, I'm not being funded by either of these two drug manufacturers, but I'm accepting applications. I'll come in with like a NASCAR jacket if I need to, and like rep some drugs, but no one's paying me yet. Anyway. So just note there's other places for these statins to use, mostly neither moderate or low intensity, but these are the two kind of big guns we're shooting for to really get those LDL concentrations down and really have this kind of positive mortality effects. There's a new class of anti-hyperlipidemia drugs. These are called PCSK9 inhibitors. That is an enzyme which I'm not going to repeat the name of because you guys would just not want to remember it and probably just want to throw up at it. I did when I read it. So we're going to go with PCSK9, right? It's a new class from like 2015, and it's a monoclonal antibody. Have I mentioned monoclonal antibodies before? I have, right? Because we talked about asthma. Remember that omalizumab or that Xolair? That is a monoclonal antibody. That one is targeted against IgE. This one is targeted against this enzyme called PCSK9. We have two drugs here. It's called alirocumab and evolocumab. Notice how the MAB is on the end there? That's how you know it's a monoclonal antibody, right? There's an antibody targeting this enzyme. That enzyme is responsible for recycling LDL receptors from the hepatocytes. So if I block that enzyme, I leave LDL receptors active for longer. And what does that do to my LDL concentration? should go down because I'm sucking up all the LDL from the blood because those hepatocytes have a lot more receptors available. This is super, super potent at reducing HDL. There were some people in the studies who even had undetectable LDLs, and the drug companies are like, we don't know if this is dangerous or not, but they came back undetectable, which is kind of odd, but no statin's ever going to do that, at least that I've seen. But very, very potent reduction, very, very expensive, obviously because it's a protein we're having to engineer, and obviously the same sort of adverse reactions you want to be careful of, kind of as in general for monoclonal antibodies, is going to be injection site reactions and then allergy, right? Anytime you're injecting a foreign protein into a person, allergy is going to be a risk here. Okay, these are going to be used in patients who can't get their LDL down in with use of statins, or if they could not use statins, this might be an alternative. So just kind of let you guys be aware of it. Okay, so any questions on that section? All right, moving on. Let's get into our antihypertensives. First thing we're going to talk about is our diuretics. So hopefully everyone went to the bathroom, right? Okay. So anyway, so our definition here, these are going to be drugs that are increasing urine outflow, typically by blocking sodium and chloride reabsorption to cause excretion. Have you guys covered any nephro stuff yet? People are at least familiar with the kidneys from their physio pre-rec, correct? All right, I'm going to assume some base level competence with the kidneys, but we'll talk about it. If you have any questions, just stop me and we'll talk about it some more. Now, you have to have good sustained balance between sodium and chloride and water intake. And again, when I say we're blocking sodium and chloride reabsorption, just note that wherever salt goes, water wants to follow it, right? That's just how osmolality works. The more concentrated it is in the renal tubule, water's going to flow into it, and then you get increased diuresis. If you have too much fluid retention, this is going to cause volume overload. You can see pulmonary edema. You can have pitting edema, ascites in hepatic patients. If you have too little, you can end up seeing volume depletion, cardiovascular collapse. That's no good either, right? So again, there's a lot of hormones that are going to be responsible for helping to regulate this, but these are going to be drugs that directly affect the kidneys to get rid of more fluid. So kidneys receive a ton of cardiac output, even though they only make up a very small amount of body weight. And we know there's a lot of this compensatory mechanism here to prevent our bodies from getting rid of too much fluids. We call this diuretic braking, right? Because we want the body likes to maintain homeostasis. You get rid of too much fluid, you can have cardiovascular collapse. Doesn't like that. So this is where we're going to have things of activation of the sympathetic nervous system, right? So those are catecholamines like epinephrine, norepinephrine, and then the renin-angiotensin system. Have you guys talked about that yet? Perfect. All right, so this is going to be a really important concept here, and this is what limits the utility of these drugs as antihypertensives, because even though I'm losing a ton of fluids, we know that the kidneys are really responsible for increasing the release of renin, and that's going to end up producing angiotensin II. And what does angiotensin II do? Well, yeah, so it'll affect aldosterone, so have more aldosterone, which is we're going to see is important in the kidneys, and then what else? You said it. Vasoconstriction, right? So this is how we prevent, it's going to cut down on renal blood flow. It's going to try to prevent us from losing too much fluid. And so this is a really important compensatory mechanism. So you're also going to have decreased release of things like atrial natriuretic peptide, which is normally increased in like volume overload, and increases in ADH. Anyone know what that stands for? Antidiuretic hormone, right? So this is preventing you from urinating, right? Because it's going to hold on to fluid, and it's also going to activate your thirst response, try to get you to drink more and more fluid. Does anyone know why you urinate so much when you drink alcohol? I would not recommend it as students. Don't ever drink alcohol. But why do people who do drink alcohol, they end up breaking the seal, so to speak, and then they end up urinating much? Because alcohol actually prevents release of antidiuretic hormone. So they actually don't release as much antidiuretic hormone. The kidneys don't get the hint to retain that water, and so you end up peeing it all. That's why they get really dehydrated and really cranky in the morning, right? Anyway, so again, here's the kidney. We have our basic unit of the nephron. This is important to keep the physiology of the nephron in mind, because the drugs are going to work at different sites. And so it's important to know where they work, to know how the kidney can compensate for that, to know how it can overcome certain things. We'll look at that more in detail in here in just a second. So as far as filtration goes, we know that blood flow coming into that Bowman's capsule is going to flow through the glomerulus. So we're going to have some filtration of a lot of substances like glucose, sodium, potassium chloride, bicarb, amino acids, all this kind of stuff gets filtered out. A lot of it ends up getting reabsorbed. You guys know where most of the reabsorption happens? The proximal convoluted tubule. Yeah, so the very beginning portion here, we're going to see a ton of reabsorption of salt and water and a lot of these other electrolytes, glucose, amino acids, all that kind of good stuff. Now, we said that the blood flow coming into the glomerulus, do you guys remember which arteriole that's called? Yeah. It's the afferent arteriole, and we see that the one exiting is the... Okay, good. So what keeps the afferent arteriole open? What dilates that? Remember us talking about NSAIDs and how that affects the kidneys? prostaglandins. Prostaglandins are your vasodilatory. So prostaglandins are really important for blood flow into the kidney. They're vasodilatory. They keep the blood flow coming in, right? You guys know what affects the efferent arteriole? What constricts that? That's angiotensin II. Angiotensin II is really important for constricting the efferent arteriole. So essentially what you can imagine, kind of like, I use it kind of like a garden hose kind of an example, where the efferent arteriole is kind of like you putting a kink in the hose a little bit. You block off that the exit of blood coming out of there, and you're opening up the input essentially, and so that creates pressure, right? So if I were to cause vasodilation on the efferent arteriole, that's going to relieve that pressure. I get less filtration happening, and my GFR, my glomerular filtration rate, goes down, okay? This is important for some of the side effects for these drugs we'll look at in a second. If I get rid of the prostaglandins, I'm going to constrict on that afferent arteriole. That limits the amount of blood getting even to the glomerulus in the first place, okay? So you kind of see why NSAIDs can affect kidney function, right? And we're going to see how they also can affect the antihypertensive effects of these drugs a little bit as well. So anyway, so we're filtering a lot. Proximal tubule is really important for reabsorption of a lot of this stuff. About 60 to 70% of that filtrate gets reabsorbed there in the proximal convoluted tubule. Next up, we have the loop of Henle, which is super important for helping to concentrate urine. I'm not going to go super into the detail here. Just know that this is where a lot of salt gets reabsorbed during the ascending loop of Henle, right? Because there's a thin and a thick segment of that. The thin segment, the descending segment, usually is going to have a lot of water being reabsorbed, but salt is really, really important for reabsorbing for that ascending portion of it, right? This is going to be important because the loop of Henle can be affected by what type of diuretics? Loop diuretics. There you go, right? So we're going to look at our loop diuretics and see how these work here. Next up, we have our distal tubule. This is where our thiazide diuretics are going to be working, and this is also where we're going to have a little bit of aldosterone action. We mentioned aldosterone is really intrinsic in that renin-angiotensin aldosterone system. We're going to see this come up here as well. Again, mostly just a little bit of sodium, not nearly as much as a loop of Henle, but a little bit of sodium gets reabsorbed here. And then we have the collecting duct. Again, this is where things like aldosterone and antidiuretic hormone are going to be working. This is primarily where you see a lot of the concentration of the urine, right? So us being able to determine how concentrated or dilute we want the urine to be is managed in the collecting duct, okay? So just know that's where our potassium-sparing diuretics are going to work, and we'll talk about those in a few minutes. Okay, first class we'll talk about is the loop diuretics. These are the most potent diuretics we have. If you've ever seen someone who's been on a loop diuretic, they will pee out liters and liters and liters of urine, right? Because these are so potent because they are blocking sodium, chloride, and potassium reabsorption in that ascending loop of Henle. I'll show you a picture of that in a second. They're basically blocking reabsorption. More sodium and chloride stay in the renal tubule. That means water's going to go into the renal tubule, and then it's going to get peed out, right? So again, very dilute urine you're going to see here. You're also going to be losing a lot of electrolytes. This is why potassium is going to, you see hypokalemia, you can see hyponatremia if you have too much of this stuff. 4 drugs in this category. We have furosemide or Lasix. I'm sure most people have heard of that one before if they're kind of familiar with the hospital sort of setting or EMS sort of setting. Does anyone know why it calls Lasix? Because it lasts about 6 hours. So a little bit of trivia for you guys, yeah. There's bumetanide, there's torsemide, and this kind of oddball ethacrenic acid. This one is used occasionally if you have a sulfa allergy. People will, if you could not receive furosemide due to allergy, you could use ethacrenic acid instead. Not used super commonly, but again, these are the loop diuretics we're going to run into. Very, very potent drugs. Just know that the only difference here is really that some are going to be more potent than others. Just know that it changes the dose. So, for instance, 40 milligrams of Lasix is going to be, equivalent maybe to 10 milligrams of bumetanide. Again, can be wide ranges of doses you're going to see here. So you imagine here's the lumen. This is where the urine's going to be. Probably should have colored this yellow. The blood here, the interstitium. Typically, the flow of salt is going to be reabsorbed through this thick ascending loop of Henle in this direction, right? So there's a transporter here. It's going to be bringing in sodium, potassium, chloride. If I block this, I'm going to lead more of the electrolytes out here in the tubule. More water is going to flow along with this, and I'm going to get rid of that urine. Okay. Notice here as well that you're going to have issues with this transporter here, and so this means you're going to have decreased reabsorption of magnesium and calcium. Right. So you lose a lot of electrolytes when you use a loop diuretic: magnesium, potassium, sodium, calcium, all this stuff you're going to end up losing in the urine. You should be aware of that. So again, this can inhibit sodium reabsorption by about 20 to 25%. This can increase your urine output up to 4 liters a day, so quite a bit extra urine. Will increase potassium excretion and then calcium and magnesium, as I kind of already mentioned. So some side effects you can see with this. These are going to be, some of those are going to be shared across the diuretics we're going to talk about, so I'm not going to kind of belabor these points kind of ad nauseum as we go through this, but this will be important as we kind of are talking about it. So loop diuretics, or kind of all diuretics, can potentially cause hyperglycemia. And you're like, well, why does that make sense? Kidneys are trying to get rid of the salt. Like, why do you get hyperglycemic? A lot of this has to do with this reflex mechanisms to prevent your body from getting rid of too much fluid, right? So your sympathetic nervous system gets activated, right? Your sympathetic nervous system, when else does that get activated? Fight or flight response, right? So what does blood sugar do in a fight or flight response? Should go up, right? Because you want to be able to provide sugar to your brain and all the muscles. That way you can run away from a bear or alligator or whatever it happens to be, right? Probably more like the alligators here in Florida. Regardless, though, you can also see some issues. So if potassium's low, you can see impaired insulin release. You can see that by activating alpha-2 and beta-2 receptors, you can have decreased insulin release and increase in glycogenolysis, right? Because glycogen gets stored in the liver for later use. You start to break that down. Then you have what step next to produce blood glucose? So glycogenolysis into? Well, once it gets to the wherever it's going to, it'll undergo glycolysis. But think gluconeogenesis. You guys heard of that term? That's where gluconeogenesis happens, and then it gets released into the bloodstream, right? You can also see some systemic vasodilators as well that can have some issues here. So again, when the kidneys are losing a lot of fluid, the kidneys sense that and they say, hey, we need to hold on to some more of this. And so one of the things it can do is increase the amount of blood flow getting into the kidneys because it thinks it doesn't have enough. And so this is where prostaglandins are going to be utilized to open up that afferent arteriole. Now, if I have an NSAID around, I'm inhibiting that, you can see how that would not really be all that effective. So I could actually limit your kidney blood flow. And NSAIDs in general blunt the effect of a lot of antihypertensives, okay? Some other things we're going to see that the renin-angiotensin system will get picked up. We'll kind of go into overdrive a little bit because, again, decreased fluid in the kidneys gets detected by that juxtaglomerular cells. You can hear that, and the macula densa and all that. That's going to stimulate the renin-angiotensin system to increase angiotensin II. Also, increase aldosterone. Aldosterone is really important for causing reabsorption of salt at the expense of potassium, as we'll see in just a little bit here. And then also antidiuretic hormone, as we mentioned, keeps you from peeing. It's going to hold on to more fluid. That kind of makes sense? So the body's trying to hold on to stuff, so once it gets a sense that it's losing a ton of fluid. The other big thing to worry about with these patients is uric acid. Typically, you see uric acid levels will increase for patients. So again, who might that be a problem for? Gout patients, right? Because not only are you causing fluid contraction within the body, which can lead the concentration of uric acid to go up as well, but there's also some other mechanisms where we're going to be holding on to more uric acid that's been filtered in the glomerulus. So just be aware uric acid levels go up, and that's going to be happening with the majority of these diuretics. Okay. So you can also see a little bit of a mild alkalosis occur here. A lot of it has to do with enhanced hydrogen ion secretion, so just know that your pH may go up a little bit in response to this. Other sympathetic effects include having your lipids go up a little bit. So again, that could be hypertension along with hyperlipidemia kind of go hand in hand in a lot of cases. So this is the main thing. Also, the big key point to note here as well, loop diuretics retain efficacy even in really poor kidney function. So even if I have someone who has a creatinine clearance less than 30 mLs a minute, I can still use my loop diuretics to increase diuresis, okay? So doesn't mean that the kidneys are functioning very well. It doesn't mean they're actually filtering things or reabsorbing things appropriately, but they can still get some fluid out, okay? That may be important enough if you have a patient who's pretty edematous. So again, this will not be the case when we talk about our thiazide diuretics in a little bit, but loops still continue to work, okay? All right, so some therapeutic indications for loops include things like pulmonary edema, nephrotic syndrome. Someone can't really regulate their serum plasma or cannot regulate plasma fluids due to loss of protein. They have cirrhosis of the liver with ascites, hypercalcemia, so they can actually end up getting rid of some of that calcium. Heart failure, they typically end up being pretty edematous, renal failure, and then hypertension. Loop diuretics are not great for hypertension. Those reflex mechanisms I mentioned are such that you may see the blood pressure go down a little bit as your blood volume goes down, but as soon as your body starts to put the brakes on that, blood pressure goes back up pretty much to baseline. So I only mention them here because we're going to use them in a lot of other stuff, congestive heart failure and other things, but just know these are not great antihypertensives. They're great at getting rid of fluid, not great for dropping blood pressure. So mentioned as far as adverse effects go, we talked about the hypokalemia, we talked about the hyperglycemia, the gout issues. This is another thing you run into, especially with patients who have, other ototoxic drugs on board. Do you guys remember any other ototoxic drugs we talked about? Antibiotics, vancomycin, and aminoglycosides like gentamicin. Those are big ototoxic drugs. So imagine a patient with poor kidney function, they're building up fluid. What are you going to give them to get rid of the fluid? Probably a loop diuretic, and they're also on vancomycin. Think of these ICU patients. That can lead to ototoxicity as well. Hyponatremia, as we see, you already be getting rid of those fluids, and those are the primary side effects you're really going to be worried about. And again, a lot of this stuff you're going to be seeing with most of these diuretics. We'll notice a few key differences as we go forward, so keep in mind that there's going to be some differences here. Okay, with drug interactions, I kind of mentioned the NSAID issue. This actually will blunt that natriuretic effect. When I say natriuretic, do you guys know what that means? Just means pee salt. Yeah, it basically just means to pee out more salt. So natriuretic, if you ever hear, or natriuresis, that means peeing out more salt, essentially. So that's what we're referring to. We talked about the aminoglycosides and potentiating that ototoxicity. And there's some cases where you can run into issues where if other drugs are dependent on things like potassium, and you're losing a lot of potassium, guess what? You can aggravate those conditions, and namely like arrhythmias and things like that. Drugs that are very dependent on renal function, things like lithium we use for bipolar disorder. If you put someone on lithium and loop diuretic, they end up holding on to more lithium. They end up getting levels very high and cause toxicities. I've seen a few cases like that. So just be aware, there's lots of drug interactions, but in general, most of these drugs are maintained, or they are useful and pretty well tolerated for the most part, but again, usually use it for this kind of fluid issues. So like my mom, I probably mentioned, she has a ton of medical issues. She has kind of poor mobility and likes to get just a ton of fluid kind of built up on her legs, and she'll just take Lasix whenever that happens, you know, kind of as an as-needed thing, pees it all off, and then she's back in business, essentially, right? So some of these things will be scheduled around the clock. Some people will be on this for short-term courses or just as needed. So there's several ways to utilize these drugs. Okay. Next up, we have our thiazide diuretics. Kind of, you can break these down, and you can just consider all these thiazides essentially, but we have actual thiazides, which include chlorothiazide and then hydrochlorothiazide. Anyone know what you kind of abbreviate that to? Yeah, HCTZ is going to be that one. I had one patient ask for Huctaz. Took me a while to figure out what the heck he was talking about, but it was the HCTZ he was talking about. We also have some thiazide-like diuretics, just kind of lump them all in the same thiazide category. But there's chlorthalidone, there's metolazone, and then another one called indapamide. I've never actually seen indapamide used, but certainly we see a lot of chlorthalidone, chlorothiazide, hydrochlorothiazide, metolazone occasionally. We'll talk about when to use that one. But just be aware there's quite a few thiazides out there. These are going to be working in the distal convoluted tubule. They're working after the loop of Henle, right? So we're in the distal convoluted tubule. These are going to block specifically sodium and chloride transporter in that luminal membrane, okay? That's the primary mechanism of action. Don't really worry about these two so much, but just be aware this is the primary therapeutic mover and shaker for this drug. Imagine again you have your lumen here, the urine, you have the interstitium with the blood. This is blocking a transporter here. Notice it's not blocking a potassium transporter, right? Because that one for loop diuretics was sodium, potassium, and chloride all in one transporter. This one is just really sodium and chloride. The other thing you're going to note here as well is that you're going to be losing sodium and chloride. You also end up losing some potassium as well. So, and as far as efficacy goes, thiazides are never as potent as a loop diuretic. Like loop diuretic could just pee out liters and liters a day. This will probably be maybe half as much as that, maybe a third to a half as a potent of diuretics. But you're still going to lose some potassium. The one really key difference here I want to note is you end up absorbing more calcium, right? So by blocking this transporter, there's some downstream effects, but you end up reabsorbing more calcium. This can be important for patients who have a history of kidney stones, right? Is there another name for kidney stones? And nephrolithiasis, yeah. So you have someone, I'll talk about that in just a second, but just know that thiazides, you reabsorb more calcium. So again, major action, they're increasing sodium chloride excretion. They're going to have a pretty modest increase in urine output. You're also going to lose potassium and magnesium. So you're still going to lose a lot of electrolytes. Calcium is really the only thing you hold on to. Now, you have a decreased renal calcium excretions. That means you're holding on to more of it. And so if I ever say like, hey, use this for hypercalcemia, this is specifically in the case of people who have a history of kidney stones. Being in Florida, we have a lot of calcium in our water, so a lot of people have kidney stones. If you ever see someone who has that and is on a thiazide, they are trying to do that to prevent that calcium from getting in the renal tubule where it precipitates out, right? So by reabsorbing more of it, the concentrations are lower in the nephron, and then you don't have the chance for that precipitation. All right. So anyway, continuing on with our thiazide diuretics, again, we see very similar kind of side effects here. Yes, ma'am.
I'm sorry. Can you explain one more time how it's helpful to give them that if they're hypercalcemic?
Yes. So people with hypercalcemia, they're going to be filtering more calcium through the glomerulus, right? So their concentrations in the lumen are going to be higher, correct? Higher concentrations of calcium in the nephron means more likely to see precipitation of calcium oxalate crystals, for instance, right? So if I were to increase reabsorption of that calcium, with the thiazide, less concentration in the kidney, thus you're going to have less likely to have that precipitation. Yep, no problem. Anyway, yes, so we're going to see hyperglycemia. Again, it's pretty mild for the most part, but it's one of those things you just kind of, you'll expect, and just kind of, make sure the patient's diabetic medications maybe are okay, or, whatever you have to do. You may fix their insulin regimen a little bit. You're also going to end up seeing, you may have a little bit of an acute uric acid excretion, but chronically, uric acid is going to build up. You're more likely to see gout in those patients. You got to be careful with that. And then some risk for acute decreases in GFR. This kind of goes back to all these diuretics where dropping blood volume very significantly, especially for elderly patients who may not have a lot of hemodynamic reserve. You may see kind of a brief period where you see a drop in GFR as a, because again, primarily where does the body want to send blood to? They had to pick two organs, for instance. Heart and the brain, right? So the kidneys can take a hit from that. Or kidneys to kind of take a backseat, even though we know they're very metabolically active and all of that. So just be aware, big doses of diuretics, you may see a sharp drop off in their GFR. Typically it comes back with time as they kind of get used to it. Okay, very similar indications to thiazides, the loop diuretics. The one big difference here is going to be this hypercalcemia, renal calcium stone thing we already mentioned here, and you're much more likely to use these for hypertension, right? So you're going to find that thiazides, you've kind of already, a few of you have alluded to it, either from the homework assignment or from other classes. The thiazides are one of the go-to drugs for hypertension, right? So we see that this works best in elderly patients, obese patients, African Americans, and people are what we consider to be in a high sodium retentive state. Basically, what kind of happens is when you have kind of high sodium retention and over a long period of time, you end up seeing that your vasculature, the vascular smooth muscle, or the endothelium surrounding the blood vessels tends to get waterlogged, essentially, where sodium kind of deposits into that tissue. It's going to hold on to more water as well, and that does what to the diameter of the vessels, do you think? Should narrow them, right? Because they're more puffy and they're more full of fluid, so they're going to end up getting a little bit more narrow. Obviously, that increases pressure in the system, right? So one of the things that thiazides tends to do, even though you see the same kind of reflex mechanisms as you do with a loop diuretic, that acutely you're going to see a short-term drop in blood volume. As a reflex to that drop in blood volume, you're going to have an increase in cardiac output. But chronically, you're going to notice that ends up balancing out over a period of time, and you end up losing that kind of waterlogging effect. You end up getting a bigger diameter of the blood vessels. The pressure goes down. You have some direct vasodilating effects of these thiazides. So again, all this is going to be very useful in helping to drop the pressure and have a sustained drop in blood pressure for these patients, right? So if you had to imagine, again, it's not super well drawn, but if you were looking at a patient's different kind of cardiovascular parameters, looking at their blood pressure, plasma volume, and then total peripheral resistance, which is kind of that measure of how constricted your blood vessels are, and then cardiac output. You'll notice if I were to start a diuretic here at this point, you may have not a big effect on the blood pressure, right? You'll certainly see plasma volume start to go down as you start to diurese that, and then total peripheral resistance we'll try to compensate for that by trying to squeeze down. Less blood volume, you want to increase that pressure, right? So that's kind of a natural response to that. Cardiac output's going to go down a little bit over a period of time, but what you'll notice is with chronic dosing, things tend to kind of even out, right? So cardiac output will kind of pick back up to normal levels, essentially. TPR is going to go down to lower than it was before due to those that waterlogging effect you're getting rid of. And then you'll notice that while plasma volume is going to stay relatively the same, you have a sustained drop in blood pressure as long as you're on it. So again, this is nice because you have a sustained antihypertensive effect that you would not see with something like a loop diuretic. Okay. So adverse effects, we talked about the volume depletion effects already. We talked about hypokalemia. Again, you can see a little bit of a metabolic alkalosis, not usually clinically significant. And we talked about the gout effects. Again, adverse effects. The only thing you may see that would differ the thiazides from your loops is that you would see potentially hypercalcemia as a side effect. And again, we already know why that is based on the mechanism, right? Why do you think you'd see dizziness, weakness, restlessness? Why do you think you'd see that? What happens if I drop the amount of blood volume I'm sending to that brain? Yeah, so you can see that, especially with patients who are elderly, who don't have a lot of hemodynamic reserve, they are more likely to see kind of ultramental status changes related to things like diuretic effects, right? So less blood volume making to the brain, you can see a little bit of dizziness, lightheadedness, things like that. Also, you have to keep in mind, like when you're giving these to your patients, imagine like you have an elderly patient who you're giving a diuretic to. What do you think that's going to do to them at nighttime? They're going to have to get up and pee, right? So if they're not wearing Depends, like they're going to have to get up and walk, in the middle of the night over to the bathroom. Guess what can happen? They can fall. They're getting up. They're dizzy. They have orthostatic hypotension. Be careful with stuff like this, right? So this is why you generally, for those older patients at poor reserves, start low and gently titrate up, right? It's always going to be, you can always give more drug. You can't take it away once you give it, right? So be careful with that sort of thing. Okay, a lot of antihypertensives, you end up seeing some sexual dysfunction. Anytime you're regulating or changing blood flow to different areas of the body, sexual dysfunction can occur, and so this could be a reason why one patient might want to stop therapy in those cases, right? So if it interferes with the sexual life, then they may not want to take the drug. Occasionally see some constipation, and then the other big thing to note is that thiazides are not effective below creatinine clearances of 30 mLs a minute. Okay, this means once your kidney function gets poor enough, like those chronic kidney disease patients, they start to lose effectiveness of your thiazides. Loops will still work, thiazides will not, except for metolazone. That a nephrologist referred to this drug as a drug that can get a rock to urinate. Is that good of a drug? So again, poor kidney function, think metolazone. All the other thiazides will not work. Okay. We talked about drug interactions, very similar to your loop diuretics, like your NSAIDs effects, or if you were to say, like, get rid of potassium levels, it can affect antiarrhythmics like digitalis, which we'll talk more about in a later section here. Typically, you're going to use pretty low-dose thiazides for hypertension because, again, we're not trying to just get, diuresis ton of fluid off. We're just trying to look for those more chronic effects. So that's why, typically they'll recommend, say, like HCTZ is probably the most common one, maybe 25, maybe 50 milligrams. You don't really get a whole lot of extra antihypertensive effect when you get above that. So, again, typically pretty low doses we're using with these, and they stay pretty much effective. Okay. So we already talked about these mechanisms for kind of these reflex mechanisms. I'm not going to kind of belabor this point too much, but just be aware of things like having increased diuresis, getting rid of more fluids. You're going to have a lot of reflex mechanisms here. So I've talked about this already, so I'm not going to belabor the point. Just know that the renin-angiotensin system is super important here. ADH secretion. Anyone know another name for ADH? Vasopressin, if you ever hear that, another name for that is vasopressin. But again, all of this is going to be related to increasing sodium and water retention in order to maintain that plasma volume. That's really the big thing we're shooting for here. Anywho, the next thing we're going to look at is going to be our potassium-sparing diuretics. So we see, and this is going to be kind of in the distal convoluted tubule into, like, kind of the tail end of the distal convoluted tubule into the collecting duct is primarily where our potassium-sparing diuretics are going to work. And if you had to imagine what is these diuretics going to do? Spare potassium, right? We're going to hold on to more potassium. We've already seen most of our other diuretics. What do they do to potassium? Excrete it, right? We waste potassium. So these are going to be good drugs that will help to hold on to more potassium. And very frequently, you'll see these added on to potassium wasting diuretics, right? So again, that can help to blunt that effect and hold on to more potassium. Especially if you have like a cardiac patient who has a history of arrhythmias, you really don't want to screw around with their potassium levels. You want to keep them in a nice, safe range here. So anyway, a couple of things we're going to notice here is that the potassium-sparing diuretics, they're basically going to be preventing the sodium and potassium exchange here, right? So if I have less sodium being reabsorbed, meaning I have more sodium sticking out here within the lumen, you're going to find that less potassium gets sent out here as well, right? Because normally what you'll see is if you're in a kind of sodium retentive state, like you want to hold on to more fluid, you're going to hold sodium but then lose potassium. That's kind of what one of the big things that aldosterone does. But if I block that sodium intake and I leave more sodium out here, again, water follows it, I'm going to be able to hold on to more potassium. So that's kind of how you get that potassium sparing effect that you see there. So again, they're working to inhibit a couple different transporters, but mainly that luminal sodium channel is the primary thing we're going to be focused on. So again, less potassium excretion. You can see a little bit of uric acid excretion here as well, but again, usually this is not going to be good for gout patients either. Again, a lot of gout patients are not going to do well with these diuretics. And these, as far as potency goes, are even less than that of the thiazide. So again, these are pretty wimpy diuretics, not nearly as good as a loop diuretic, but primarily not using this necessarily for the diuresis effect. You're more so using it for the kind of the potassium sparing effects, which is why you add it on to a lot of other diuretics. Two drugs in this category include amiloride and triamterene, and I mentioned very often you see these in conjunction with hydrochlorothiazide, so it's another very common. I very rarely see these ever used by themselves. Similar indications as our other diuretics we've seen here already. And again, most often used in combination with other antihypertensives to help with the potassium levels, typically. So side effects, be careful with the hyperkalemia, right? So that's obviously one of the biggest side effects you're going to see with these. This is important because we're going to find that other antihypertensives will also mess with your potassium, namely your ACE inhibitors and angiotensin receptor blockers, right? So we're going to see those as we talk about them a little bit later. Also, if patients have been taking potassium supplements, this will also be synergistic with that. So again, be careful of those patients. Who's more likely to suffer, like what type of organ dysfunction you're more likely to see hyperkalemia with? Renal dysfunction, right? The kidneys are the primary space for getting rid of potassium. So if I have poorly functioning kidneys, they're more likely to hold on to potassium anyway. That's how you have those patients coming in who they miss dialysis over the weekend, like they miss their Friday dialysis. They come into the ER on Monday morning and they have a potassium like 7, right? 3.5 to 5 is normal. They come with 7 with arrhythmias and all kinds of bad stuff. So those are the people you got to be really careful about. Kind of unique things you can see megaloblastic anemia with tram-stream. I'm not sure if that's something to do with affecting folic acid or something like that, but that is kind of a unique side effect. All right, so kind of under that similar umbrella of potassium-sparing diuretics, I will also put in kind of the aldosterone antagonists. But basically, what we know of aldosterone, and again, going back to talking about steroids, this falls into that category of mineralocorticoid, right? So mineralocorticoids are kind of the flip side of the glucocorticoids. These are responsible for holding on to fluid, right? Mainly by absorbing sodium and reabsorbing water. So normally what you find is aldosterone, this is primarily working in the collecting duct, is they're going to bind to steroid receptor sites in the nucleus, right? And they're going to change protein synthesis. They're going to start to put more sodium channels in that membrane. They also make that sodium-potassium ATPase pump work a little bit better. And so this is going to help us to reabsorb more sodium, and then water follows wherever sodium goes, and so that's how you get the kind of water retentive, salt retentive effects of aldosterone. So again, this is the same picture here, but mainly by affecting aldosterone at the nucleus site. If we block that, that also means you have less transporters making it to the lumen side, thus less sodium can be reabsorbed. Okay. So the two drugs we have here is going to be spironolactone. Anyone remember spironolactone? What do we use this for before? Yeah, for hirsutism, right? For in PCOS. Why do we use it for that? Anti-androgen effects. Yeah, so this is what you actually find is that spironolactone is a partial androgen receptor agonist, right? Means it only will bind to the receptor, androgen receptors like testosterone receptors, and only partially activate them. So if you had someone who had, say, PCOS who was hyperandrogenic, right? They're having too much testosterone activity. You can give them one of this and kind of bind up those receptors and only have partial activity, so that helps to kind of bring them back down closer to where they were normally. So that's how we deal with that thing like hirsutism. That partial agonism, right? Because again, we're going to see that this can block those effects in male patients. We're going to see that's where it's going to cause some side effects. And then if you had to imagine, if you had a female patient who had relatively low testosterone activity to begin with, and I give them a partial agonist, what do you think that would do to them? Same thing as PCOS, you're going to see hirsutism. You can see changes, androgenic changes in female patients. So keep those side effects in mind based on kind of what the patient's kind of baseline testosterone level is versus what this drug is going to do as a partial agonist, right? It's not going to fully activate them. It's not going to fully block it. It's only a partial agonist. The other drug we have here is a plurilinone or Enspra. This one is typically used as an alternative to spironolactone, and I'll talk about that in just a second. So I mentioned binds that steroid receptor because, again, aldosterone is a steroid, so it's going to block those receptor sites. And it's going to be most effective when you have a high aldosterone state. Typically, the higher, more active your Renin-Angiotensin system is, the more aldosterone activity you have, so those patients are going to benefit most from that. This will block sodium reabsorption and also decrease potassium loss. So you're going to lose more sodium in the urine, you're going to hold on to more potassium, why you can still consider it a potassium-sparing diuretic, right? You'll see more calcium being excreted and really not a ton of effects on lipids or glucose. So pretty modest. And again, not great diuretics either. These are typically used as an adjunct to other diuretics. So we can use this for our primary aldosteronism because it will help to, if you have too much activity here, it will help to bring that down to a manageable level, used in conjunction with other drugs for hypertension. Now what's interesting is you can use an aldosterone antagonist for some late stage CHF patients, and we'll talk more about that in a later section down the road. So just kind of keep that in the back of your mind. Then for other edematous conditions, you can also use this as well to help kind of get rid of the fluids in conjunction with other diuretics. Now, the adverse effects are pretty unique for the aldosterone antagonists due to these kind of androgenic effects you're going to see here. So again, weak androgenic effects, partial agonists. So for men who already have high testosterone activity, if you were to drop that down because you're blocking up those receptors and having partial agonist effects, you see gynecomastia, you can see testicular atrophy that can occur in men. For women, menstrual irregularities, because now you're bringing them up to a higher level of androgen activity. Hirsutism can happen here. So the reason, because of that, a lot of people don't like spironolactone and they will not want to be on that. Eplerenone is going to have a lot less activity here, so that could be an alternative, right? And again, when you think about like a lot, like you guys remember on that homework what birth control a lot of you recommended the patient to be on? Yeah, so I had that drospirenone in it. That one's actually an anti-androgen activity anti-androgen effect. So it's actually very similar to how we can use spironolactone. That would actually do the same thing. So again, think back to those hormones and how it can have different activities based on the actual drug itself, right? So that's why in a lot of cases, some women, they're just on a regular like ortho Sprintec or some kind of oral contraceptive with a progestin that has, say, mineralocorticoid activity like aldosterone. That's why they end up holding on to more fluid, right? Versus if I use something that had anti-aldosterone effects, you could actually end up losing some fluid, right? So when you see weight gain or weight loss, that usually kind of goes back to that progesterone effect. So again, that's a little bit of a tangent, but just be aware that these effects come back up in kind of weird places. Okay. One of the last classes we'll talk about for diuretics include our carbonic and anhydrase inhibitors. Clinically, these are not used super often for diuresis purposes, right? We're going to use some of these in some other cases that we'll see. Pretty pitiful as far as diuretic effects because, again, these are going to be working the proximal convoluted tubule. Can be working very early on in the nephron, and that means that even if you did have an increased release of sodium and water into the nephron, it's going to get reabsorbed at the loop of Henle. It's going to get reabsorbed at the distal convoluted tubule. It'll get reabsorbed at the collecting ducts. So they're pretty wimpy as far as that goes because there's so many other opportunities to reabsorb that water. But they're going to work by inhibiting carbonic anhydrase, which is an enzyme that we've seen previously. You guys remember where we affected that before? It's in the eye. Glaucoma, yeah, we use carbonic anhydrase inhibitors in the eye, help to decrease aqueous humor production. We're going to use the enzyme here for a different purpose, but you guys remember what carbonic anhydrase did? Combine CO2 and water together to form bicarbonate, and it breaks it apart as well, right, into CO2 and water. So we'll see that in a picture here in just a second. But by blocking that enzyme activity, you're going to lose more bicarb in the lumen, which means you can actually end up having an acidosis from this drug, which is a little different than the other diuretics. You can lose you're still going to lose some potassium, you're going to lose some sodium, but again, pretty meager effects compared to a lot of the other diuretics. The three drugs we have here include acetazolamide, dichlorphenamide, and methazolamide. Acetazolamide is the only one I ever see really used, so this is the primary one I'd probably be asking about for testing purposes. But Diamox is a pretty common one you may run into in the hospitals. So anyway, the way that it would normally happen is if you have the lumen here on the left side and the interstitial space on the right, typically bicarbonate itself is not able to cross that luminal membrane, and it has to be converted over into CO2 and water. So normally carbonic anhydrase would break these two apart and allow for reabsorption. Eventually later on it gets reabsorbed onto the interstitial side. By blocking that, you end up preventing that breakdown. You have more bicarbonate stuck out here in the renal tubule, and then it gets just peed out, right? So by peeing out your bicarb, what does that do to your pH of the body? It's going to lower, so you can get more of an acidosis actually from that, right? So it is unique to these drugs versus the other diuretics we saw. Okay, other uses. The primary thing we use this for is for glaucoma, as I already mentioned. In some cases, you can use it for epilepsy. Typically, if you get more acidotic, you have a more difficult time causing a seizure. I'm not going to talk about that too much here, but you may see it used for that. You can use it for altitude sickness. So again, you can put a patient on it prior to. It actually helps to decrease CSF production. Right, so CSF, if you get too much pressure in there, that can cause a lot of headaches and things like that. So we can actually use this for mountain sickness related to altitude, and then also for head injuries. This can help to decrease swelling within the brain. So again, not used as a diuretic frequently, but that's technically the category it falls into. Mentioned the metabolic acidosis, potassium depletion, again drowsiness due to some of the CNS effects, but again pretty well tolerated. The last category we're going to talk about here are the osmotic diuretics. How do you guys think these work? They're osmotic. Yeah, they're going to work by osmosis, right? They're highly osmotic materials here. Basically, these get filtered through the glomerulus, but they cannot be reabsorbed in the renal tubule. Basically, they have a very high osmolality within the renal tubule. That's going to draw a lot of what with it? Water. Yeah, it's going to draw a lot of water into it to try to dilute out that high osmolality. You don't lose as much sodium as you would see with the other diuretics, but basically by that high osmolality, draw a lot of water with it, and you just pee it right out. So we had things like mannitol. Anyone ever seen mannitol used in a clinical setting before? Yeah, we don't use these a lot as diuretics. Things like urea, glycerin, like, we don't use it very often. The primary one I'll focus on here is mannitol. We actually use this occasionally for patients who have head injuries, or they have increased intracranial pressure. The same way that this can draw water off of the kidneys and increase diuresis, this can do the same thing to the brain. Remember that blood-brain barrier prevents a lot of transmission of solutes and things like that. If you have cerebral swelling due to increased CSF or due to head injury or something like that, you can get this high osmolality substance in the blood that can draw water off the brain and actually lower intracranial pressure. So that can be life-saving in some cases. So if you ever work in a surgical ICU or in a trauma center, this is something you may see used occasionally. You guys know any other high osmolar substances I can use instead of that, like another electrolyte? What concentrations of normal saline come in? 0.9%, right? So 0.9% sodium chloride. We use things like 3% sodium chloride, or even in some rare cases 23.4%. It's a very, very concentrated sodium. And actually do the same thing when given in the veins. It helps draw fluid off the brain. You can pee it right out. All right, so just for tangent's sake. We'll use this occasionally for acute renal failure, but not super commonly. But this is more mannitol used for things like cerebral edema and swelling to try to pull fluid off. Okay, so that's it for the diuretics. Moving on, we have the RAS inhibitors. Again, this is standing for the Renin-Angiotensin Aldosterone system. Right, so we know this is super important for regulating blood pressure. It will stimulate secretion of aldosterone, helps with renal blood flow, as I mentioned, causing constriction of that efferent arterial, sodium excretion. There's some CNS effects, autonomic nervous system effects. It involves everything. Renin-Angiotensin system is super, super important for regulating all sorts of things throughout the body. So we're going to monkey with it. We're going to try to prevent it from working so well. Basically, the kidneys, when they detect low fluid or low sodium concentrations in those juxtaglomerular cells, they will increase release of a product called renin, right? And then that will affect this conversion of a product called angiotensinogen. Anyone know where this comes from? The liver, yeah. So it comes from the liver. This converts over to angiotensin 1. And then there's an enzyme called angiotensin converting enzyme, right? This will catalyze that conversion from angiotensin 1 to angiotensin 2. This is the primary thing we're going to be concerned with because it's going to affect the adrenal cortex to increase aldosterone secretion, which we know aldosterone holds on to fluid, increases blood pressure. It's also going to cause direct vasoconstriction. ACE is also important because it metabolizes a product called bradykinin, which is typically a vasodilator, right? So we're going to see there's going to be some side effects associated by affecting this, okay? Yeah, my stuff forward. I always freezes with you guys, I don't know why. Anyway, so I mentioned the rate of renal release is going to be managed by the kidneys. Also, other things like the renal baroreceptors, which baroreceptors detect what? Pressure, absolutely. The macula densa, the sympathetic nervous system, all of that can affect renal release. So decreased renal perfusion increases renal release. So I'm not going to belabor that point too much, but just know the macula densa also responds to decreases in sodium and chloride, which makes sense because if I was decreasing sodium and chloride concentrations by using diuretics, that's going to again stimulate renal release to try to compensate for that. All right. Sympathetic nervous system is also going to be innervating things like the juxtaglomerular cells. We're going to see that beta-1 receptors help to stimulate renal release as well. So we're already starting to see here where some beta blockers can be useful for hypertension. A lot of it goes back to this renin effect here. Okay. So angiotensin II itself is vasoconstrictive, stimulates that aldosterone secretion, causes that renal vasoconstriction. You guys have covered this already in another class, I'm sure, right? Very injured. Scattered head nods, I want to assume you guys aren't just falling asleep, but yes, you guys will cover this, so I'm not going to go over this too much, but just know this also will stimulate things like vasopressin or antidiuretic hormone, so this again holds on to more water. What is antidiuretic hormone? How does it hold on to more water in the kidneys? Do you guys know? So aquaporin channels, if you ever see aquaporin channels will get put in the collecting duct, and that's directly for reabsorbing water. That's one way it does it. Also stimulates the thirst reflex as well, right? The other big thing to note here is that angiotensin II is really important for causing cardiac cell hypertrophy and remodeling after MI. Why is this so important? Is the heart like super effective after an MI when it starts to repair itself? Does it just go back to like being like an 18-year-old's heart? No, right? It's going to get fibrous. It's going to get hypertrophy because it's having to work against such a high blood pressure. It just gets wrecked, right? And so angiotensin II is really, really important for causing a lot of that remodeling. So if we can inhibit that, if you can prevent that remodeling, this is why ACE inhibitors end up having mortality benefits for these patients. They live for longer because their heart stays good for longer. Okay, so this is going to be a really important point here when you're looking at treating patients with hypertension. You have to look at, do they have a previous MI? Do they have diabetes? Do they have all these different things that make them really good candidates for something like an ACE inhibitor? Okay. So anyway, so other things we can see with the angiotensin II and the renin-angiotensin system, it can worsen the hypertension, it can worsen congestive heart failure, right? Because what's kind of the core issue with the congestive heart failure heart? So how good is their cardiac output? Pretty poor, right? We call it their ejection fraction is low, right? The amount of blood coming in can't be effectively pumped out. You know, have you guys talked about preload and afterload? What's preload? Yeah, the volume of blood coming back to the heart. What's afterload? Pressure's pumping against, right? So anytime a muscle's having a process or trying to pump against really high pressures, that high afterload, it's got to pump really hard. And what happens to the muscle when it works really hard? Thickens, it gets hypertrophied, it gets stiffer, it's less likely to open up as well. It has that less compliance, so it can't fill with as much blood. So all these things are really important because usually patients with CHF are going to have a high renin-angiotensin system activity, right? So this is why it's really important to affect that. Diabetic nephropathy, we can also see this as well. This will help to prevent some of that remodeling that occurs in the kidney. So we can see that ACE inhibitors or things that affect the renin-angiotensin system are going to be nephroprotective. Not only the cardioprotective, they're nephroprotective, which is super important for making sure we can watch. Because again, do kidneys regenerate on their own? Good Lord gave us 2 of them, right? But we see that you have damage to those being done over time. And again, you don't normally see decreases in kidney function until you've lost about 50% of actual active nephrons, right? So you are damaging your kidneys for a long period of time, and then all of a sudden you see, oh, now all of a sudden kidney function starts to drop. So if we can stave that off, if we can prevent it from getting any worse, that's going to be a good thing. And this is where ACE inhibitors can help with that as well, right? So again, drugs that inhibit this system have a significant effects on morbidity and mortality. This is why these are good drugs. Again, I'm not being funded by them, but if they would like to, I will allow it. Anyway, so looking at the physiologic actions here, if I inhibit ACE, if I inhibit that angiotensin converting enzyme, I will drop down that amount of Ang2 vasoconstriction. That will help to decrease renal vasoconstriction. That will be important for some acute effects we'll look at in a second. You'll see less aldosterone, less sodium reabsorption. You're going to have less norepinephrine being released. You're going to see decreased bradykinin metabolism. This is going to be important for a side effect a little bit. And then again, normally there's a negative feedback loop. This will get inhibited. So you may be producing a ton of renin, you may be producing a ton of Ang1, but that enzyme stays inhibited. Doesn't matter how much you produce, it's not going to convert it to Ang2, right? So all the ACE inhibitors have an identical mechanism of action and similar clinical effects. Some of them end up being prodrugs. You guys remember what that means? Inactive initially, that to be converted by the liver. So a lot of these are actually oral medications. I'm not going to have you memorize which ones are prodrugs, which ones aren't. I'll delineate via that, but you don't need to know that. And then most of them end up getting eliminated through the kidneys. So those will be important. You may see some retention of these drugs if they have really poor kidney function, which can be important for, if they have, too profound of a hypotensive effect. It could be related to poor clearance. So we have quite a few of these because, again, this was like a blockbuster drug when they were first coming out. It's like a big deal. A lot of commercials out there for them, a lot of Me Too drugs, which is why there's like 2 pages full of these ACE inhibitors. But what do you notice about the names? Ends in a pril. So if you see a pril on the end of a drug, chances are it's an ACE inhibitor. So you can go with that. Notice here when they get converted to their active form, enalapril turns into enalaprilat. Anyone ever work in the hospital will probably have seen enalaprilat used. It's called Vasotec. This is the IV form. So we actually give it in the already active form. We don't have to wait for it to be converted by the liver. So just a little side note there. We have captopril, lisinopril. Lisinopril is a very common one. It's one of the free drugs over at Publix or Walmart. Enalapril, benazepril, fosinapril, and then trandolepril. And then we have quinapril, ramipril, perindopril, and then moexapril. I don't know why I put perindopril twice, but that is a typo. Anyway. So most of them work with just once daily dosing, which is really good for compliance. I mentioned that Lasix lasting 6 hours. So how often do you think you'd have to dose it? Every 6 hours, you have to take it pretty frequently, right? So we're looking for things that are only going to be once daily dosing, maybe twice daily dosing if we have to, because that helps to increase compliance. Again, why you see a ton of combination drugs where you may use 2 different diuretics together in one pill, or you might use an ACE inhibitor plus a diuretic, or a beta blocker plus something, So we can try to combine these as much as we can to try to get one pill for the patient to take, because again, these patients' compliance is going to be the most important feature here. So the main therapeutic uses, we're going to use this for hypertension. This helps to decrease total peripheral resistance, decreases both systolic and diastolic blood pressure, and so also help to decrease or diminish that left ventricular remodeling that occurs due to elevated pressure, due to that elevated afterload. Again, can you reverse those effects and get like a brand new 18-year-old heart? No, you can't do that, right? You can only stave off further damage being done. Hopefully, slow it down, if not stop it altogether. But obviously, everyone's gonna, everyone's heart's gonna wear out at some point. We can try to keep it working as well as we can for as long as we can. Okay. This is also preferred in diabetics, mainly due to the microvascular complications thereof. Mainly this kidney protective effects helps keep the kidneys working for better for longer, essentially. So. Again, you can use this for patients with CHF, and this is one of those things, those metrics that you're looking at. With insurance companies, they want to make sure their patients are being taken care of. Because again, if you're not prescribing the right type of medications, the right therapies, and they end up back in the hospital, they want to pay you for that. Generally, no, right? So these are some like checklists of things you really want patients to be on, because one of the things you'll see is that readmission rates are, if you have a readmission that happens too soon from when a patient was discharged, they don't want to pay for that because they assume it was your fault that they didn't get discharged in a well enough state to to fly, essentially. So that's one of the things that they're going to look at. But this left ventricular dysfunction, which is kind of core to the issue with CHF, primarily systolic CHF, helps to decrease that remodeling, decreases afterload, will have to diminish preload to some degree, and help improve cardiac outputs. These are all really good things. And we see this helps to decrease incidence of MI or hospitalizations. It's been borne out in the studies. And in general, anyone with left ventricular dysfunction should receive an ACE inhibitor unless otherwise contraindicated. So, and again, you can see how this kind of sick cycle occurs, where you have someone who has, say, reduced cardiac output, or say, let's even start at high vasoconstriction, right? You're going to see these kind of elevated cardiac filling pressures that can lead to cardiac remodeling. You can see that they're going to be in an enhanced state where they're releasing more renin and angiotensin II. All that's going to lead to more cardiac remodeling, and that leads to CHF. And guess what? Starts all over again. So typically these things kind of beget one another, and so it's important to try to nip it in the bud somewhere to try to prevent further remodeling from occurring, right? So that way you can prevent the CHF from getting worse. We'll talk much more about CHF a little bit later on. I think it's not like charts. I think that's what I've determined. Okay. Anyway, so post-MI, these are good for dropping or preventing myocardial remodeling after infarction, as I kind of already mentioned, and also they have improved mortality after MI. So again, another drug a lot of your post-MI patients will be on, because again, MI can potentially precipitate CHF in a lot of cases. So again, this is why we try to put these on for these patients. Mentioned the diabetic nephropathy. Basically, this is going to help with decreasing that glomerular pressure and affects that remodeling of the kidney. Because again, someone with kind of chronic blood pressure, chronic hyperglycemia, that tends to increase those pressures in the glomerulus, and that kind of shreds it essentially to where it becomes less and less functional. So by inhibiting that efferent effect on the kidneys, by inhibiting that efferent arterial, you kind of loosen up the pressure a little bit, right? And this is going to be talking about, we'll talk about the side effect here on renal function, but overall, it's going to be a good thing for patients. Okay, side effects. Dry cough is probably the most common non-life-threatening side effect you can see with these patients. I don't know if anyone's ever lived with someone who's has an ACE inhibitor cough. It can be pretty maddening just because they're coughing all the time and it never stops. A lot of it's thought to be due to bradykinin buildup. We mentioned if you block the effects of angiotensin converting enzyme, bradykinin also gets metabolized by that, so its levels build up, right? So that can lead to this cough. It can be something you see a little bit more commonly in women, and it's one of the main reasons why people discontinue ACE inhibitor use, and we'll switch them over to a different class of drugs, which we'll see here in just a minute. You can see hyperkalemia, right? And why would you think you'd see hyperkalemia with these drugs? What does it do to aldosterone? Decreases it, right? We see that by inhibiting that renin-angiotensin system, you decrease aldosterone synthesis, less aldosterone in the collecting ducts, which means we're going to be losing more sodium, but we're also holding on to more potassium. So ACE inhibitors, angiotensin receptor blockers, all are going to raise our potassium. This is important because if I add it on with the spironolactone, guess what? Synergistic effects. Or if they're on potassium supplements, synergistic effects here. So watch potassium. You're going to definitely see an increase in their potassium. Patients with renal disease who you might be putting them on it for that purpose, they're going to be more likely to see a bigger rise, right? Because they already have issues excreting potassium to begin with. Okay, so be careful with that. Again, hypotension, you can see, especially with older patients, they can have this kind of first dose effect. So sometimes we'll actually recommend dosing this at nighttime, so that way they kind of sleep through a lot of that. Again, be careful. You put them on this and a diuretic, and they want to get up in the middle of the night, and all of a sudden they wake up. And what happens when you kind of change sitting positions, and all of a sudden lack of blood flow to the head. Orthostatic hypotension, right? So that can lead to falls, it can lead to syncope, things like that. So you got to be really careful with that one. Again, start low, go slow is always the name of the game for these patients. All right, so renal function impairment. This is a short-term kind of an acute issue. I mentioned that by blocking angiotensin-converting enzyme, you decrease angiotensin II levels. That's going to cause a vasodilation of the efferent arteriole in the kidneys. This leads to an acute decrease in pressure. GFR goes down, right? This is a short-term thing and can be mitigated by starting at low doses and gently titrating up. So for patients who have poor kidney function or are dependent on Ang2 for that pressure, those are the ones that are going to likely see issues. You and me, if we have healthy kidneys, you shouldn't really see any issue with their kidney function. But again, this is a transient thing for those with kidney disease. Okay. Now, the kind of rare, more serious side effects to talk about include things like angioedema. Very rare. This is not really the same as anaphylaxis. It'll look very similar, but again, treatment's not going to quite be the same. But basically, they get a lot of really rapid swelling within the throat, the nose. Like airway obstruction is really the big thing that can kill these people if not treated early. Some people can get it within the first week. Some people can get it after being on the drug for years. It is very unpredictable who's going to have this angioedema response. Just let them know that, hey, if you ever experience these symptoms, call 911 right now, and their tongue will probably be sticking out of their mouth and say, oh, come get me. Whatever. I don't know if you can say angioedema, but try to get someone out to you immediately, right? A lot of it's thought to be due to bradykinin accumulation. Too much bradykinin is thought to have led to this risk for angioedema. So we'll see how we can mitigate that with another class of drug in just a second here. The other big thing, ACE inhibitors are going to be category X for pregnant patients. We do not want to use this to treat hypertension. I'll talk more about this when we get to kind of women's health issues in the next pharm class, I think. So just kind of keep that in the back of your mind, but these are not going to be recommended for pregnant patients, okay? Again, this should not be probably indented, but NSAIDs are going to have a blunting of the antihypertensive effects of the ACE inhibitors, just like we see with any other antihypertensive, like the diuretics and all of that. So just be aware of the interaction. NSAIDs generally are not going to do anything, any favors for antihypertensive drugs. Okay, so on the flip side of the angiotensin II, the angiotensin converting enzyme inhibitors, we have other drugs that can work by blocking the angiotensin II that's produced from the receptor itself, right? So this can be useful for patients who cannot tolerate an ACE inhibitor. So say, for instance, someone had a lot of cough due to that bradykinin. By switching them over to something that just blocks the receptor, you can have a ton of angiotensin converting enzymes still active and breaking down bradykinin. That's totally fine. Angiotensin II that's produced will not affect those receptors. Okay, so therapeutically, ACE inhibitors and ARBs are going to be primarily interchangeable. It really just depends if they can tolerate an ACE inhibitor. Most of the evidence out there is probably more with the ACE inhibitors. So a lot of people just kind of go to that as their default, generally are cheaper. But they need an ARB. This is the option they can go with. Okay. Primarily as AT1 receptor is the main one we're focused on. These drugs will be able to inhibit that, the enzyme or the angiotensin II from affecting that receptor. So again, kind of already went through this already, but again, AT1 receptors are really important here for this vasoconstricting effect. The aldosterone release, all of that good stuff that we want to inhibit by affecting that renin-angiotensin system. You hung up again. See if I can eliminate all charts from your guys' slides. I know it looks normal to you guys. I just have a black screen over here. All right. So basically we see that these are very good tightly binding drugs at the AT1 receptor, and it leads to all the same clinical effects you would see with an ACE inhibitor, right? So again, therapeutically, these are pretty much interchangeable from my standpoint. Now, looking at the subtle differences here, we're going to see that ARBs are better at blocking the AT1 receptor, obviously, because they're directly affecting that. Again, clinically not super important. The big things you're going to note is that we saw that bradykinin is kind of vasodilatory, right? So you see a little bit of a disadvantage. You may not see full as big of an efficacy with the ACE inhibitors. I'm sorry, with the ARBs as the ACE inhibitors do that bradykinin effect. But again, that can be beneficial if someone has chronic cough with an ACE inhibitor. Some people also feel that due to that bradykinin effect and kind of sparing that with the ARBs, that if someone had angioedema to an ACE inhibitor, you could safely put them on to an ARB. I don't know a whole lot of providers that are that kind of gung-ho about potentially giving someone else angioedema, so most of the time they just kind of limit that. But again, you're balancing out the risk for angioedema versus the mortality benefits that we know occur for most patients. So it's kind of a plus-minus kind of situation. So again, don't really worry if they're prodrugs or not, but we have things like candesartan, olmesartan, losartan, azilsartan, iprosartan, irbesartan, telmisartan, and valsartan. Again, very similar where all these companies wanted to produce Me Too drugs, they get new patents, and they can sell them and say, this is the best ARB we got out there. And they're like, well, how is that better than this other one that's just went generic? It's the best one. Don't worry about it. It's definitely the best. Just use this one. And they'll buy lots of nice lunches and stuff, and you're like, yeah, it is the best one. They had the best food, so I'm going to go ahead and prescribe this. Okay. Usually the way you choose is typically on things like, what can your patient afford, right? So what did they tried previously? They did not have a good reaction with one. Perhaps a different one may work okay for them. But yeah, a lot of it comes back down to cost. So if they can get a free lisinopril from Walmart, that's what they would probably prefer rather than going with a super expensive brand name ARB, right? So kind of keep those things in mind. Again, the similar therapeutic uses, you can use these interchangeably with the ACE inhibitor. So again, I'm not going to belabor these points, but hypertension is the main use. You can use this to help with that left ventricular dysfunction, diabetic nephropathy, all works just the same. Same side effects as well, so hyperkalemia, hypotension, impairment of that renal function, and the same category X rating for that from a pregnancy standpoint. Again, in heart failure, start low and go slow. You can always give more drug. You can't take it away once you start it. Big differences, though, no cough really associated with this one, and then lower incidence of angioedema if you switch from an ACE inhibitor. So again, not a zero risk, but a lower risk. Okay, any questions on those drugs? All right, moving on. Next, we have our calcium channel blockers. What do you think these drugs do? Yeah, sometimes we try to make it easy for you guys, right? Now, we don't make it easy with some of the class names. Just know there's lots of different types of calcium channels that are out there. The main ones we're going to focus on for our purposes are the L-type calcium channels. These are going to be really important for affecting the myocytes, affecting the myocardium, and affecting the vascular smooth muscle, right? We're going to see that based on the type of drug you're dealing with, you're going to find that it will either have really good effects on the heart, and effects on the vasculature, or they may just affect the vasculature. And so we're going to delineate those out. Basically, we're going to categorize these into, and I'm not going to have you know these class names necessarily, but I will have you know the difference between a dihydropyridine and a non-dihydropyridine. You'll basically put these two drugs together into one group of non-dihydropyridines versus the dihydropyridines. Okay? You can say DHP for short, maybe a little easier for you. So anyway, these L-type calcium channels, as I mentioned, are found on the vascular smooth muscle, on the cardiac myocytes, and also on the cardiac nodal tissue, mainly the SA node and the AV node, right? These are going to be really important because what does this nodal tissue do for you? Yes, that's the rate of the heart, right? So if I can affect this, what do you think it's going to do to heart rate? If I block it, it does. Slow it down, right? Absolutely. So these can be very good for especially tachyarrhythmias that are supraventricular in origin, as we'll see here in just a little bit. So again, imagine as far as heart physiology goes, have you guys seen these kind of action potentials and about the electrolyte shifts that occur during that? Hopefully, we'll talk a little bit about it here. I'll talk more about it in the antiarrhythmic section. But essentially, again, during the EKG, the P wave is what? Atrial depolarization, right? You guys should know this, right? QRS is what? Ventricular depolarization. What's a T wave? Ventricular repolarization. Where's the atrial repolarization? It's covered up, right? The ventricle is way too strong, covers it all up. Anyway, so essentially we have our SA node, we have our SA node here. We have our AV node, just kind of found at that the divide between the atrium and the ventricles. And by affecting that, we can affect heart rate pretty significantly, right? So we're going to see blocking calcium influx, and I'll show you the electrolyte shifts in just a few minutes here. You can see pretty good effects on that. The ones we're going to talk about, these non-dihydropyridines, are going to have really good effects on the myocytes as well to decrease contractility, right? So you're going to see decreases in cardiac output along with decreases in heart rate. So that's going to be important things to remember there. So normally what you would expect to see, and so the difference here is that these are one of our SA and AV node cells. These are our pacemaker cells, and versus our myocytes here. What do you kind of notice the difference between these two? What's the difference between pacemaker cells and regular myocytes? So the pacemaker cells, they fire on their own, right? That's the whole point of having pacemaker cells, is that they have the leaky sodium channels that once they get to a certain threshold, action potential, right? And then all the other myocytes are subservient to these SA and AV node signals, right? They're subservient to these pacemaker cells. So basically what you see here is that cardiac myocytes, or ventricular myocytes, not going to fire unless it gets a signal from one of these pacemaker cells. So essentially what you can see here is that it normally have sodium influx, causing this kind of slow increase. Once it hits the action potential threshold, you're going to notice a ton of calcium influx. Well, if I block calcium influx at this point, what do you think that does to the depolarization? Slows it down, right? So again, you can see why you're going to have a slowing of the heart rate when you have calcium being affected here, these L-type channels. On the flip side of that, when you have these cells that are only going to be activated when an action potential affects it, right? Because you get that propagation of the action potential through the heart. You're going to see that sodium is the main cause of this kind of rapid rise in electronegativity, right? And the increase in voltage. And then what you notice here is that calcium is really important. You kind of see this here, causing that plateau effect. So if I were to block calcium influx, what do you think that would do to the contractility? Say if instead of having this nice kind of plateau effect, I block calcium influx, and instead it goes kind of like this. It's not going to be as strong, right? That contraction will not be as strong because that change in potential is not going to be as big. You're not going to get that plateau effect, right? You would see. So again, cardiac automaticity, the heart rate is going to go down. Also, the contractility is going to go down as well. So, and you can kind of see how these are going to be working to affect calcium, because again, typically on the myocytes, what you're going to see is that you have these T tubules that kind of extend through a lot of the myocytes as you have calcium being let in during the action potential. This is going to cause that sarcoplasmic reticulum to release a bunch of calcium, and that will cause the actin and the myosin to start to bind together and cause a contraction, right? Remember muscle physiology? That's similar for the myocytes essentially. So if you can block that, you kind of block that release from the sarcoplasmic reticulum, less contraction occurring. Same thing you can see here, a similar picture. Again, less calcium coming in from the outside of the cell, less of it being released from the sarcoplasmic reticulum, less of the actin and myosin binding together, meaning it's just not going to be able to bind as strongly. You won't get as strong of a contraction. So it gives you an idea of that contractility, why that goes down. Similarly, calcium channels on the vascular smooth muscle, if you were to say block calcium influx here, similarly you're going to have less calcium being released from the sarcoplasmic reticulum, less of it's going to be able to interact here, and this actin and myosin will not be able to bind super tightly, and thus you're going to get smooth muscle relaxation or constriction. Relaxation, right? So blocking calcium influx causes relaxation of the vascular smooth muscle, okay? So that's going to be really, really important for understanding how these drugs work. So we're going to see the calcium channel blockers, their effects on the veins is that at therapeutic doses, they don't really do a whole lot to the venous tone. They're mainly going to be affecting on the arterial side, if anything. And so at therapeutic doses, you see they decrease afterload because they're affecting the arteries directly, try to open them up and relax them to allow that pressure to go down. And they don't really have any effect on preload because the veins are going to be relatively spared in these cases. So, and then looking at their effects on the myocytes, what you find is that the myocardial cells, because they're so dependent on calcium through those channels, you're going to find that they tend to, again, slow down heart rate, slow down contractility. But you can find that depending on the drug, it can affect both the myocytes and also the arterial side. They tend to be a little bit more sensitive to these calcium channel blockers. So, we'll see here, again, you can break them down into non-DHP or non-dihydropyridines and then the dihydropyridines. Mainly what you're going to notice is that the dihydropyridines are going to work primarily on the vascular smooth muscle. I mean, their biggest effects are going to be on blood pressure, lowering blood pressure. The non-dihydropyridines, there's two of them we'll talk about in a second, they are going to be working primarily on the heart, slow down heart rate, slow down contractility. They also will work on the vasculature as well. So they kind of have a more balanced kind of effect here. Okay, that'll be important when we talk about side effects in just a little bit. So what do we use this for? You know, primarily things like angina. What is angina? Chest pain brought about by what? I get chest pain for lots of reasons. What's this one? And maybe some inflammation, but primarily, what does the heart need to pump? Needs energy. Where do we get energy from? Glucose. What else? Oxidative metabolism. Oxygen. We need oxygen to the heart, right? Yes, you got to have oxygen. So if you don't have enough oxygen coming to the heart responds by saying, ow, that hurts. Your arm starts to go numb. Your jaw starts to hurt. It's trying to tell you need more oxygen getting to the heart. And it's usually being impinged on by things like those plaques that are starting to build up. The coronary vessels are not super patent anymore. So if we can do things like slow down the heart rate, what do you think that does to oxygen consumption by the heart? decreases, right? So that's why you can see if you have someone who's on one of these drugs that maybe was inhibiting calcium influx of these myocytes, they would have better exercise tolerability, right? Because they were able to get around before that oxygen demand really kind of kicks up. Because normally people with angina, when do they experience symptoms? On exertion, exactly. So if you can try to help with that, that's one of the big things we're going to see when we talk about angina a little bit later on. Primary uses as well is going to be hypertension. We can use these for some supraventricular arrhythmias. Obviously, they're supraventricular, meaning they're originating where? Yeah, above the ventricle, so probably in the atria. It's kind of the only other places it could be. So these are going to be very useful because, again, they're blocking that transmission from the SA node to the AV node down to the ventricles. By slowing that down, you can help to treat a lot of those supraventricular arrhythmias. Supraventricular tachycardia is one of the big places we'll see that used. So I don't know if in my EMS buddies have ever seen a cardizem being used on a patient with SVT. Will slow down the heart pretty significantly, so those are good for that. We can use it potentially for some diastolic heart failure. Some cases for cerebral ischemia, so I'm not going to get too big into here. And we'll talk about migraine prophylaxis in the neurology section later on in the class, probably in Pharm 2. So the primary thing I want you to know is that these non-dihydropyridines, diltiazem and verapamil, those are your non-dihydropyridines, they are going to have good effects on vasodilation. They're going to have good effects at suppressing the automaticity of the heart, both SA and AV node, and then they suppress that contractility. So the heart is going to be slower, blood pressure is going to go down, heart's not going to be as hard. Okay, those are the non-dihydropyridines. Dihydropyridines, on the other hand, are going to have very good vasodilation, almost no effect on anything else as far as the heart goes. Now, for instance, we know we have to keep a balance between cardiac output and total peripheral resistance, right? So if I were to say cause vasodilation, cause hypotension, how does the heart respond to that? What does cardiac output do? TPR goes down, cardiac output should go up, right? So how does that go up? Heart beats faster and harder. Yeah, absolutely. So heart beat faster and stronger. So again, what you can see with actually the dihydropyridines, because they only affect the vasculature, one of the side effects you run into, because you're dropping the blood pressure, is that the cardiac output is going to try to pick back up. So you're going to see a reflex, increased heart rate, tachycardia, right? So again, that's where one of these things where, and I do this clinically, where if I have a patient who overdosed on an unknown heart medication, I can look at their blood pressure and their heart rate and get a sense for what they could have taken. If they're hypotensive and tachycardic, that lets me know that they're taking something that is affecting primarily the vasculature, not something that's a direct cardiodepressant. If they're bradycardic, hypotensive, that may lead to something like a non-dihydropyridine, like verapamil, right? So these are little things. Think about the physiology, and it informs a lot of the side effects you can see there, right? Okay. So we're going to talk about diltiazem first. And you'll see that diltiazem and verapamil, they're pretty much interchangeable for the most part. We're going to see very similar side effects, very similar drug interactions that we'll see here in a second. Either of them are going to be available either IV or PO. So we use these a lot for, as I mentioned, the supraventricular tachycardias, like in the ER type setting, or like on the ambulance. They probably have stock of one or the other, depending on what the hospital formulary is. We will use this for things like angina. We use it for hypertension. And again, I mentioned that supraventricular tachycardia. So they have like an AFib or an A-flutter or like an SVT. We will use it for those. We'll talk more about that a little bit later on. So the only thing to really note here is that it is metabolized by CYP3A4. We're going to find that it's also going to be an inhibitor of CYP3A4. Has a pretty short half-life, but that's why we give an extended release product for a lot of these, and that way they can have kind of longer duration of action in the patients. So adverse effects, these are the big ones to kind of note here. Because it will affect the vasculature, you can see things like peripheral vasodilation, so you can see flushing, headache, hypotension can be a big one for patients with kind of poor cardiovascular reserve. And then you'll notice those negative inotropic effects. So you can see AV block being induced here, bradycardia, someone who's already poor left ventricular dysfunction, who has CHF. These non-dihydropyridines are pretty bad drugs for them, because if you depress left ventricular function even further, that can exacerbate their CHF and can exacerbate them being able to deliver oxygen to the body. All right, so these are going to be relatively contraindicated in those patients, as we'll see. The other big thing, as far as the smooth muscle of the GI tract, does that require calcium to function as well? That's the question. So it would lead you to think. Yes, absolutely. So if I block calcium from being influxed into the GI tract, guess what does that do to the smooth muscle contractions in the GI tract? Slows it down, right? So again, constipation. Now we can understand how we see that side effect. So this can be a big deal with the non-dihydropyridines. You can slow down the GI tract. Imagine you had chronic pain patients on opioids. Also causes constipation, exacerbated by this. So keep these drug interactions in mind. As far as the CNS effects, this is primarily due to potential decreased blood flow to the head, so you can see drowsiness, dizziness, things like that. And then some risk for sexual dysfunction, some gynecomastia. I'm not really sure where that comes from. It's not really an anti-androgen at all, but it is one thing that is noted. And then also gingival hyperplasia. There's a few drugs that actually do that. They can actually cause the gums to start to kind of hypertrophy and can kind of start to overtaking the teeth. There's cool pictures if you ever want to look that up. So contraindications, these are pretty relative, but advanced heart block, because it's going to worsen that, as I already talked about, hypotension, and then kind of relative contraindications, it can worsen heart failure, and that GERD, can again worsen the GI effects, as we saw already, if you kind of slow down peristalsis. So it kind of makes sense why you have these kind of relative contraindications. Now, diltiazem, also being a CYP3A4 substrate, is also going to be an inhibitor of CYP3A4. So the primary thing you're going to see is that because of this, you can inhibit breakdown of things like statins, right? Talked about simvastatin. Like what can happen if you prevent breakdown of a statin? Cholesterol will probably be high. What else is going to be high? Their creatine phosphokinase, when you're breaking down their muscles, right, and you get rhabdo. Think about this kind of side. Their LFTs are going to be high because you're causing hepatotoxicity. Right? Think about this kind of interactions there. There's several other drugs. Again, we're primarily going to focus on the ones we've already talked about for this test. So, look at your things like your beta blocker. Look at things like your statins as kind of being the primary ones here. It also affects this protein called P-glycoprotein. Don't really worry about that one so much. Just know that it's an efflux pump that will, by inhibiting it, you increase levels of these drugs as well. So it's another mechanism for that to occur. And they could also have additional kind of synergistic effects with other drugs that affect the heart, right? So if I were to add this onto something like a beta blocker that blocks beta-1 receptors, which is already a cardiodepressant, you're going to see synergism there. So just be careful with other cardioactive drugs. And again, other drugs that affect CYP3A4 can also affect diltiazem. So you can kind of see this kind of cycle that happens there. A lot of drugs, especially, do you guys know what we would use these drugs to treat? Antivirals, yeah. So these are HIV drugs. So again, these are HIV patients are always notoriously bad for drug interactions. Well, as we'll see when we get into Pharm 2. Again, just be aware the synergism as well from the pharmacodynamics. Being cardiodepressant can cause hypotension. Other drugs can do that as well. Okay. On the flip side of diltiazem, we have verapamil. Again, I'm not even going to really talk about this one too much because, again, you can think about the two of them as being pretty much therapeutically interchangeable. There's not a whole lot of difference as far as drug interactions, side effects. They're all pretty much similar for the most part. And again, most of the time it just depends where you're working at, what they want on the formulary. So whatever they can get for cheap, essentially. Again, verapamil, very even effects on both vasodilation and suppression of the cardiac tissue. Again, don't remember how many plus signs go in each box. Just look at the general trends here. Okay. And you'll also notice, while it does metabolize by 2C9 a little bit, CYP3A4 is still going to be the primary drug interaction we're going to focus on, and it will be possibly testable. Constipation is going to be a big side effect. You see this a little bit more with verapamil than you would with diltiazem, so that can be another really problematic thing for some of your patients. So anyway, mentioned the constipation, but most of the other side effects are going to be identical to diltiazem. Same contraindications, nothing new there. Same drug interaction, right? It's a CYP3A4 substrate and an inhibitor of CYP3A4, meaning that if you were to give this on top of the statin, top of propranolol, levels are going to go up, right? Okay. And same thing. Okay, so that's our non-dihydropyridines. Next we have our dihydropyridines. Again, these are primarily going to affect what? The vasculature, right? So this is primarily going to be for antihypertensive purposes, really should not have a direct effect on the cardiac cells. So this is going to include things like amlodipine, or Norvasc is probably the most common one people have heard of. Nifedipine, nicardipine. This is actually a really good one. We use IV for help as a continuous drip that we use for ICU patients to try to get their pressure down. You can use this occasionally for hypertension, angina, most common causes or cases we'll use this. We also have drugs like felodipine, isradipine, and isoldipine. Those are going to be used for hypertension. And then we have one called nimodipine we actually use for subarachnoid hemorrhage, which you can find after someone who has a head bleed like that, is you can have the vessels be kind of very vasospastic. They tend to kind of constrict and dilate kind of at random. And so this kind of helps to prevent some of that. Because again, we know that it's going to help just relax that smooth muscle, essentially. Most of them are going to be PO only, except for nicardipine. That one we do have available, I mentioned, as an IV drip. But again, I'm not going to focus on IV versus PO for the test. Just know that these are kind of your options. Okay, so again, primarily the vasodilation effects we're going to see here, primarily hypertension is the main use. So as far as interactions go, they are metabolized by CYP3A4, but they are not going to inhibit it, right? So you run into less drug interactions, but just know that this one you could use safely with like a simvastatin, but you wouldn't want to put an inhibitor on top of that because that can then affect both drugs. The only kind of things I kind of note here is that the half-lives can vary pretty greatly depending on the one you're using. So if it's a short-acting drug, I would recommend using an extended-release product that it prevents a lot of kind of peaks and valleys in their blood pressure. It's very easy with a short-acting drug like one of these to drop their pressure pretty low, and you don't want to do that. So, but other ones like amlodipine, pretty long half-life, pretty good for kind of getting good, consistent levels in your patients. Okay, so due to the peripheral vasodilation, the adverse effects are going to be a little bit different here. Mainly peripheral edema can be one of the primary things you're going to run into, where they have kind of the edema that's kind of forming in the periphery and the legs. Primarily is where you see a lot of that just due to kind of gravity. Also, that rebound tachycardia I already mentioned can be one possible thing. The dyspnea and wheezing can be related to kind of fluid in the lungs essentially by relaxing some of those vessels there. You can possibly see some fluid, kind of third spacing. Other than that, though, the only other action you really would want to worry about is gynecomastia with nifedipine a little bit more commonly than things like diltiazem, but it could be one thing you run into with your patients. As far as contraindications go, if they had severe aortic stenosis, you would not want to use that because, again, with aortic stenosis, you're kind of blocking the outlet of the heart essentially from the aorta. If you're vasodilating a ton, you're kind of lowering that pressure and the heart can't compensate for that, then you can see decreased perfusion of the tissues, which again can be problematic. So you want to do that. And then potentially after a recent MI or something, you don't want to necessarily do anything to increase cardiac output or increase cardiac rate because that increases oxygen consumption. That can be bad. So just be aware you may not want to use this directly after an MI. Okay, so again, as far as interactions go, if you have another antihypertensive on board, again, this could be synergistic. This might be therapeutic. It might be a good thing for your patients, but it may not be. And as far as interactions from the kinetic side, just look for other CYP inhibitors on board that can affect these drugs, namely 3A4 inhibitors. Okay. So that's it for the calcium channel blockers. I'm going to go a little bit into beta blockers real quick and see how much time I can maximize here because we have so many slides to go through. I don't know if you guys have looked ahead, but there's a lot. Anywho, so beta blockers. What do you think these guys do? Block beta receptors, absolutely. So we already talked about these a little bit. Where else do we see beta blockers? Glaucoma, right? We see all this in glaucoma. So these are basically going to be blocking either beta 1 or beta 2 receptors primarily. Where do we find a lot of beta 1 receptors? The heart. Yeah, heart's going to be the primary place. Where do you find beta 2 receptors? In the lungs, right? So beta 2 helps with bronchial smooth muscle relaxation, right? That's why we talked about that interaction where if I was blocking those receptors, how good is my albuterol going to work? Potentially not as well, right? That's why we see a relative contraindication with using non-selective beta blockers, as we'll see with our asthmatic patients. Also, beta 2 receptors on the vasculature. Do you guys know what that does? If it relaxes smooth muscle in the lungs, it stands to reason it would do what to the smooth muscle of the vasculature? I would relax it as well, right? So again, in general, beta 2 tends to be smooth muscle relaxing in general. But anyway, so the primary thing we're going to see here are beta blockers are going to cause competitive inhibition of beta 1 receptors, preventing things like epinephrine, norepi from binding to those receptors and increasing heart rate. You also see that it helps to block that renin release, so that helps to decrease angiotensin II levels as well, which is why we can see it being effective for treating blood pressure. Then I mentioned watch out for that pulmonary blockade here, because again, that could work to decrease that responsiveness of the beta 2 receptors in the lung. So we already mentioned that one before when we talked about asthma. So other things you can see are going to be the CNS effects. This is kind of interesting that the more lipophilic a beta blocker is, in particular one of the kind of big ones we talk about is propranolol, being a very lipophilic drug, the more penetration it has into the blood-brain barrier, right, and gets into the brain. And when you do this, you can actually end up seeing things like depression that can occur. You can end up seeing worsened nightmares and hallucinations, and it's tough because when you have an elderly patient who's already experiencing dementia, and say we're to start them on one of these lipophilic beta blockers, and all of a sudden they're complaining of these new nightmares, or they're just not acting right. A lot of that can be related back to, well, maybe it's one of the new drugs, maybe they're not getting worse, it's just something I did to them, right? Think about that. Also can induce migraines. So again, there's lots of different clinical effects we're going to see with this as we'll move forward. Has anyone ever heard of the Beers list before? You know what that is? So when you go to a restaurant, they hand you the list, has all the beer. I'm just kidding, it's not that. It's for elderly patients, right? So it's a list of drugs you do not want to give to elderly patients due to possibility for things like orthostatic hypotension and risk for falls or changes in mentation and things like that. The things like lipophilic beta blockers go on that list, and so I urge you to look at it sometime just so you can see kind of the list of drugs that falls on there. It's a pretty big list, but you kind of get some hints for things you might want to be careful of in your geriatric patients. Anyway. So the differences in beta blockers we're going to see is that they will differ in selectivity. And then when I say selectivity, what do I mean? Yeah, so whether it's beta 1 or non-selective, right? That's kind of the difference in there. You'll also see that some of them are going to be renally eliminated, some are going to be hepatically eliminated. I'm not going to quiz you guys on that necessarily. Just know that some patients with renal dysfunction may do better with the hepatic one. Some patients with hepatic dysfunction may do better with the renal one. It just depends on what the organ dysfunction is. I'm not going to talk about intrinsic sympathomimetic activities. Actually, don't even worry about this one. Just kind of blank it from your memories. You never even saw it. It was not there to begin with. And then this is actually somewhat important. You see this membrane stabilizing effect. This can actually be useful to help certain beta blockers be good as antiarrhythmics. If we can stabilize the membrane of the myocardium, it can help prevent arrhythmias from actually coming in and causing some issues there. So I'll talk about a few that are going to be important for that, especially in the antiarrhythmic section later on. And then we'll see there's actually 3 generations of beta blockers. We'll have our non-selective that affect beta 1 and beta 2 pretty much equally. We'll have selective beta blockers that affect beta 1 primarily. And we'll have this kind of 3rd generation that has a hodgepodge of like other effects. And we'll see it does things like block alpha 1 receptors. If I did that, what would it do to the blood pressure? Raise it or lower it? Because alpha 1 does what to vascular smooth muscle when you activate it? Constricts it. Right, so imagine constriction and cause pressure to go up. If I block that, alpha 1 antagonist, I would see pressure go down, so that can be beneficial for helping blood pressure. You know, things like potassium channel openings can be useful for antiarrhythmic properties. So we'll talk about these a little bit later as we get to individual ones. So in general, this is a naming convention that helps some people, may not help everyone, but in general, and there's going to be exceptions to this rule, so be careful of that. N as in Nancy through Z tend to be your non-selective beta blockers. Okay. So if the first letter of the beta blocker starts with an N, a P, or a T, or an S, typically it's going to be a non-selective beta blocker, right? If it's A through M as in Mary, it typically is going to be a selective beta blocker. When we get into the 3rd generation, that rule kind of goes out, so those you have to kind of remember by themselves. But in general, you can look at a lot of these and kind of know right off the bat, is it selective or not, okay? So you have things like, Nadolol, Penbutalol, Pendolol. Propranolol is probably the biggest one you're going to see used most commonly. Sotalol gets used as a antiarrhythmic occasionally, but just know that these are going to be your non-selective beta blockers. These would be less appropriate in your asthmatic patients because it could potentially be blocking those beta 2 receptors, right? Also know that they can differ based on their lipophilicity. So things like propranolol have really high lipophilicity. They're more likely to see those CNS changes in elderly patients. And just know that, don't worry about this ISA, that's that intrinsic sympathomimetic activity, don't worry about that. The membrane stabilizing effect can be very useful for helping to prevent arrhythmias potentially. So again, that's why we say that with propranolol. So it hangs up on me again. All right, the next group we have are our selective beta blockers. It kind of considers like a 2nd generation. These are primarily going to block beta 1, includes things like acebutalol, atenolol, bisoprolol. I know it's kind of the A through M kind of thing here. Metoprolol is a very common one you may see being used. Again, these are all going to be beta 1 selective. Esmol is a really good one. This is a short-acting drug that we can use IV. It's very good because whenever you give a drug via continuous drip for like hypertension or something, you really want it to be short-acting so you can titrate it very quickly. Because again, if it has a short half-life, that means how long does it take to get steady state versus a longer half-life drug? I mean, half-life steady state. 4 to 5, right? So if it has a very short half-life, that means it gets to that steady state a lot quicker, right? It can titrate a patient's blood pressure very easily. So if they have too high blood pressure, turn it up, and it changes pretty quickly. If it has too low blood pressure, turn it down, and it's out of the system very quickly, right? So those are some things to consider when you're utilizing these like continuous cardioactive drips. But Esmol is a good one for that. That's why we call it Brevibloc, because it's a very short-acting beta blocking agent. And then that 3rd generation, notice these kind of fall outside of that naming convention. But we saw betaxolol previously for glaucoma use. But we have a couple here, including Carvedilol or Coreg. That's a very common one. We'll see, actually Cardiolol we saw in glaucoma as well. But Labetalol, these are kind of the 2 primary ones you're going to run into. Carvedilol gets used a lot for CHF patients occasionally. We'll talk about that later. And the Labetalol is a really good IV one you could potentially use in the hospital setting as well. Notice here they have things like alpha 1 blockade, which again helps with that blood pressure to help bring that down, which is really good. And even things like Coreg has like antioxidant, anti-proliferative effects, which is good after MI to help prevent some of that remodeling that occurs in the left ventricle. So again, some additional benefits you see with these drugs. So I'm going to go ahead and cut it there. Do you guys have any questions? Thank you for sticking with me. I know it's a pretty fast-paced stuff, but I think it's a lot of good information. You'll find that when we get through this section, a lot of these drugs are going to pop up again. So there's no point talking about them all over from scratch in those cases. So get a good familiarity with them now because we're going to talk about them a lot going forward. Okay. All right. I'll see you guys next time.